Good afternoon. We'd like to welcome each of you and thank you so much for coming and being a part of this workshop regarding the health care. At this time, we're going to stand and recite the Pledge of Allegiance, and then we'll have a moment of silence. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Our moment of silence. Thank you so much. All righty. We'll go ahead and see if there are any public comments at this time before we move into the meat of the workshop. Any public comments? Mrs. Michael, you have none? Okay. So we'll go ahead and move into the meeting. We will deal, number one, we will allow the People One Health Services representative to come at this time and share with us.
Come on, over here at the microphone.
Yes, sir, I'm sorry.
On record.
And if you will state your name and address, and then you can go into what you're sharing with us.
Sure
Yes.
thing. Thank you, everybody. So I'm Jordan Taradash, CEO over at People One Health. So our address locally here is 6100 St. John's Avenue. So what I'd like to do, put together a short presentation just to, and I know many of you folks have seen this before, just a reminder of the People One Health Services, and then just some of the comparing and contrasting points. I do want to say before I dive in that although I know Marathon is another model you're looking at, I am here to show a compare and contrast. The Marathon model and the people that work there are phenomenal, and it's a great model. I'm just going to show some of the differences between those two. So nothing here is to disparage anyone. Okay. Okay. So just as a quick reminder for those of you who have seen this before, so this is the scope of services that is included in the People One Health model. So at the top here is what you see is this direct primary care. So it is a robust, unlimited access to primary care for your folks. There are long appointment windows, 30 minutes, 45 minutes, 60 minutes. So your folks are not rushed through a care model. There's real time for them to be heard and listened to and cared for. It's a deep one-on-one relationship with our care teams here. It comes with hundreds of generic medications that are included in the model. Thousands of labs. It's something like 3,300 labs. And then because the folks in our office, our medical assistants, don't have to worry about insurance, what they are doing is care navigation. So if your folks need care that comes outside of the office, we are helping you set appointments, helping you navigate the healthcare system. So the top box there is this direct primary care. In full candor, this is very similar between models like Marathon and People One Health. Where some of the differentiators come into are the green box and the mustard box below. So as part of our care team, there is a primary care physician, but there's also a registered dietitian to help folks if they're working on weight loss or lifestyle or diabetes management or hypertension. There's also going to be a licensed clinical social worker as part of the care team to help with behavioral health and any of the challenges on that end. There's also a clinical pharmacist that's part of the care team. So for your folks on medications, if they can't afford them or are having adverse interactions or just need questions about pharmacy, all of these care team members are part of the People One Health care team and servicing your folks. We also have access to 75 plus subspecialists. So if, let's say you get your blood work done at the office and something comes up not right, instead of just sending your folks out to 5, 6, 7 specialists, and you all know how that is, it's confusing, it's scary, it's expensive, our physician has the time to consult with all of those specialists and figure out where you really need to go and then help you get those appointments. So it's a much broader access. It's not just sending your people around into the system. And then the bottom box is where we really differentiate ourselves. We have a really robust primary care and preventive health model, but outpatient behavioral therapy is also included. Outpatient physical therapy is included. Imaging, so if you need a CT scan or an MRI or an X-ray, sorry about that, that's all included in this model. Cardiac testing, if you need a stress test, if you need a sleep study, if you need a wheelchair or a brace, everything you see here is included in the People One Health scope of services. All said and done, that's about 80 to 90% of the care that your folks will need throughout all of their healthcare needs are included in this model. It's about 40% of the allowed amount. So let me just be specific about this. Typically in a primary care model, there's about 10 to 12% of the costs that can be kind of controlled through fixed costs there. Because the People One Health model is much broader, there's 40% of the cost that would typically hit your health plan is now all included in this fixed cost model. So it's about 4 times more impactful than just a primary care model, if that makes sense. Okay, any questions on this before I keep going? Okay. All right, that's a whole lot of jargon. Let me tell you a practical story about how this impacts your folks' lives. So let's talk about hypothetical Alice here. Alice on the weekend was playing sports with her children and ended up hurting her rotator cuff, okay? After a couple of days, it wasn't getting better. So I'm going to talk about kind of a marathon-like model, and then a People One Health model. So up top, it's probably very convenient, probably same day or next day in a marathon-like model. Alice will be able to go see the nurse practitioner. After a couple visits, that's rotator cuff is still not feeling better. So Alice gets an anti-inflammatory medication, and then she needs an MRI. At this point, the care would go back to the typical healthcare system. So you would need a prior authorization. There would be co-pays and deductibles and expenses for Alice. And there's, you got to go through the regular getting an appointment, and you all know it could be quite hard to get an appointment. So if Alice got an MRI, she'd probably pay a co-pay deductible. It'd have to go through a prior authorization process. It's the current healthcare system that you experience. Good news, the MRI comes back, there's no tear, but Alice needs physical therapy. So then Alice has to try to get appointments for physical therapy. The health plan will probably limit Alice to 6 or 12 appointments, and then say you have to get another authorization. So you kind of have the insurance company in the middle. You have to pay a copay and a deductible. That's kind of the standard healthcare system. Let me run you through the bottom part, which is how the People One Health model will work. So same thing, Alice, rotator cuff injury. She can get in same day and next day. It's very similar in that experience. Where the differentiator comes in is on the MRI. If Alice needs an MRI and she's a People One Health model, that's all included. So we have priority access with partners in the community. We will help Alice get an appointment, set that for her. When she goes there, she shows her People One Health card. She pays nothing. She has no copay, no deductible, no coinsurance. That's all included. Also, your health plan pays no more. That's already included in this model. There's no prior authorizations. There's no paperwork. Alice is just getting the care she needs. Okay, MRI comes back, no rotator cuff tear. Alice needs physical therapy. Same thing, that's included. So we're going to help Alice get that set up. All of her physical therapy is included, and it's unlimited. It's the doctor and Alice figuring out when she's done, not the insurance company saying, here's how many sessions you get. No co-payments, no deductibles, no cost to Alice, no cost to your health plan. All of those services are included in this concierge model. Okay? That's the care experience differentiator. Let me talk to you about the cost differentiator. So on a model like Marathon, that first experience in the health center is all included. That's part of the investment. That's part of the fixed cost. However, once Alice would go to get that MRI, there would be a copay and deductible, and the plan would pay about $1,300 for that MRI. Then the 10 physical therapy appointments, there's an additional expense of about $1,300. Some to Alice, some to your health plan. All said and told, that care experience is about $2,600 to the health plan and about $700 in change to Alice. A lot of money for anybody. In the People One Health model, if you see along the bottom here, that entire care experience costs $0. It's all included. So Alice pays nothing every step of the way. There's no co-payments, no deductibles. There's nothing getting in the way of her care. Your health plan is not paying anything additional. It's all included in that. If you just add up those numbers, because admittedly, the People One Health model, if you just look at the PMPM, it's more expensive. But if you look at the total cost of care throughout all of these services, the numbers are on the bottom there. in a typical healthcare experience, even with a Marathon a primary care model, it's going to be about $3,365 for that total care experience. With People One Health, the entire year's membership, which includes all of this care and anything else Alice needs in that model, is $1,800. So you can start to see that the total cost of care is significantly lower because of how many more services are included outside of just primary care. I know I'm giving a whole lot of information, so please slow down or stop it at any time if you need. Okay. Couple other important differentiators. Although nurse practitioners are phenomenal healthcare providers, all the People One Health offices are staffed by primary care physicians. So you have a primary care physician at the center of all of that care. Also, our primary care physicians care for folks that are 2 years and above with comprehensive primary care. And if I'm speaking, please correct me, but I think for the Marathon Health, they take care of 12 years old and up, which is super important. But anyone who has young children is going to have to seek out a different physician. At People One Health, we take care of 2 years and above for a comprehensive care. Okay, I'm almost done, I promise y'all. So the care experience is more comprehensive. The cost experience is more comprehensive. Where that adds up to for the health plan is a cumulative savings. So the blue bar here is the projected savings for the People One Health model. As you can see, a couple of things to note. Your savings to the health plan starts in year one because there's no capital expenditure to the school district. You do not have to pay for any capital expenditures. It's included. And then because of the greater depth of services, the imaging and behavioral health that are included, in the long run, this ends up being about 2 times more savings back to the school district. And those are dollars and cents that you all can allocate towards teacher salaries and other services and other facilities. So cumulatively, it ends up about being 2 times as much savings back to the health plan and to the school district. Okay. Oh, yeah, please.
So to clarify, and so everybody on the board understands, you're in an existing facility with the ability to expand.
Yes.
We, under the Marathon plan, would have to find a building, if it's not already set up as a medical, facility, we'd have to pay to have it converted. And then if there was expansion needed, we'd have to find additional space or try to grow that space. Is that correct? And you're set to you're already there.
For us, we're up and open. It costs you no additional dollars and cents. And if we expand, that's on us. We pay for those expansions. So there's no capital expenditures for the school. Yeah.
And your facility is where?
Here, I actually have a picture of it for you all. It's right here on 6100 St. John's Avenue. It's about 6 minutes from here, up and running as we speak.
And how many of our employees can you take at your current, how many are going to be offered it?
Yeah, so at the end of the day, it's up to you all kind of which population is eligible. But typically, with having everybody on the health plan is typically eligible. That is your choice. But typically, and whoever's enrolled in the health plan is eligible for People One Health benefits.
We don't have a number that we have to have or that we can only have up to a certain number.
No, this is the model is for whoever says, I want to do People One Health, this is right for me and my family. That is the only time where the school district is paying. There's no minimum. And this current office can hold up to 3,000 members. So we have significant capacity for all of your members. But if it grows, we will build another facility. And again, that's on us.
So we're not limited.
Excuse me.
You are not. You are not in any way.
You also mentioned that, and I may have heard this wrong, that if a child is below 2 years old, you guys don't deal with them.
That is correct. So for that newborn, that's very specialized care. So usually pediatric starts at 2 years and above. Yes, that is correct.
And so if some of our employees opt not to be a part of, and God forbid something happens, will you all take them? How would that work?
What's cool about this model, it is an ongoing enrollment in essence. It's not just at open enrollment once a year. So at any time, your folks can say, hey, I need help and I can't find help. I'm going to go to People in Health. So yes, folks can come in and we can take folks whenever they are ready to start receiving care. And you do not, our model is $150 per member per month. That charge only happens after someone raises their hand and says, I want to do this. Otherwise, you pay nothing for your folks.
That looks like the Jack Spine Clinic office, but I know it's right there close by on St. John's Avenue.
Yes.
You also mentioned earlier, one thing I was concerned about on doing clinicals and lab work that, I mean, as most doctors you wouldn't do lab work there at your office. You would send somebody to do lab work. But then you guys decide which, you have a team or a specialist that looks at the lab work to see if something needs more scrutiny and go to a specialist.
That's right. So we draw all the labs at that office, so you don't have to go to another facility. It's all drawn there. We get all your results. And if everything is within primary care, we'll take care of it. But if a specialist is needed, we don't immediately just give you like 9 referrals. Our primary care physician, because they have a lot of time, will actually reach out to the specialist and say, let's look at this lab work together. Do you need to see them from an endocrinology standpoint, or should I be managing this for primary care? So we are coordinating that care for you as opposed to just sending you out into the system and saying kind of good luck.
I got you.
Thank you for the question. Okay. Okay, I'll keep going. Please stop me with any others. So this slide here is just the summary of kind of the differentiators. So the People One Health model is a more comprehensive physician-led model that cares comprehensively for individuals 2 years and above. Because of the breadth of services included, it's going to lead to significant out-of-pocket savings for your members. Again, that care experience for Alice we spoke about was about $760 out of her pocket for the MRI and physical therapy. Alice may not even get that care because of how much of that. At the People One Health model, that cost her $0. So it's significant out-of-pocket savings for Alice, your staff, your teachers, their family members. On average, you'll save the district about twice as much as a Marathon-like model. This is available today, immediately ready to go with zero capital expense, and we're happy to partner and grow with you in the community as you mentioned, as there's more and more interest in the community at our expense to grow. So that's kind of the quick summary of everything.
And so if Alice was not a member of People's One, if she was not a part of it and she went and joined up, she would pay $150 the first when she joins, and then every month thereafter. Who does that $150 cover?
Yeah, from the beginning, and each time it is actually the school district that pays the membership on behalf of Alice.
Okay.
Yes.
And so still, who's covered under that $150? She, her husband, children?
Oh, okay. Sorry. Great question.
Question.
So this is a per member per month opt-in model. So let's say Alice has a family plan. It's her husband, and 3 kids are on the insurance plan. But let's say Alice has a pediatrician that she loves and she doesn't want to move the kids. The kids can stay there and just Alice can join, or Alice and her husband. So you as the plan only pay for the specific members who want to use People One Health. It doesn't have to be the entire family. It's just the individual members that join. Given that, it's capped at 3 per family. So let's say Alice says, I love this care. I want to bring everyone in, my husband, my kids. The plan will never pay more than 3 times that $150. So $450 is the max the plan would pay to cover an entire family. 3 times that rate is the maximum. Does that all make sense, that math? Yeah. Okay.
So they have to be on our insurance to have this available to them.
At the end of the day, that is your decision of who is covered. Typically, with our partners, the employer covers who's already on the insurance plan. But at the end of the day, the final determination of who you want to cover is your choice. We will just follow your direction of who you'd like us to care for.
So another question would, and maybe I misread it in the newspaper. It seemed to me like Holly Pickens, irregardless of my insurance or whatever, if I had no insurance, I could come to People One and pay out of my pocket $150 a month.
Yes, you could. Our office is open to the community, so if you didn't have care or you couldn't get access to care, as a citizen, you can come in and buy a membership for yourself. That's not what we're proposing here, but yes, that is correct.
So what's the benefit to, it's just the cost savings?
Yeah. So there's two things. So there's the care experience, that's the benefit, and the cost savings. So the first is that care experience, right? So your folks will have unlimited access to primary care, but they'll also have access to the imaging and physical therapy and labs and generic drugs and behavioral health support. So this comprehensive model is benefit number one. Your folks get unlimited access to all of this care for nothing. They pay nothing. The cost benefit is the second. So Alice and her family, your teachers and staff, will pay nothing for all of that care, so there's no barriers, but your health plan benefits too, because all of this care that's listed here doesn't hit your health plan. The plan will not be billed because the services are already paid for. So when you look at them side by side, all the costs that are saved from your health plan end up being about 30% less expensive than going to the traditional insurance model. So the district wins, and Alice wins both cost and quality and care, all the above.
And Madam Chairman?
Yes.
And so, you know, originally going back 18 months ago when we first got this presentation, and we really were, you know, the insurance committee had been working hard, you know, to bring this to us, which, you know, all this started long before I was on the board. You know, our goal is to have those people that can't afford the insurance, which is a significant number of our employees, would have this opportunity, you know, and that we would pay it. And that ultimately that would lead to these catastrophic claims going down, and it would help us, being self-insured, maintain our solvency in that process. So, you know, it's a win-win situation from three different areas. Most importantly for our employees who really deserve it and that, you know, can't afford our, you know, the Blue Cross Blue Shield plans, which, you know, I couldn't afford it either if I, you know, wasn't on Medicare. But, and the fact that, you know, people that haven't been seeing any healthcare provider that could have, you know, the start of cancer or some other disease are seen, and that treatment starts earlier so that it doesn't evolve into, you know, a major healthcare hit to us or to them from the standpoint of trying to prevent, you know, a mortality. I mean, that's basically, isn't that correct? I mean, that's what it's all about. I mean, that. And this model is and not just People One, but there are these models all over the country. This is where healthcare is going as we continue to see the increase in cost from the major, you know, insurance companies, Blue Cross, Humana, and you know. So to me, I mean, it's just phenomenal, and I think that our employees, you know, finally we'll be able to provide for them what's been needed for years.
Madam Chair.
For me, go ahead, Linda.
And Phil, I just wanted to clarify, because you're saying for employees who can't afford our insurance, are you suggesting that we offer this to all of our employees regardless if they're on our insurance?
Yes.
And if so, then you're talking about paying that $150 up to $450 per employee for every single employee we have, because there'd be no reason they would turn that down, would there? If
How much
we're
is
paying
that?
for it,
Well, I think
why would
that-
any of them say no?
that we would pay for the employee the $150 a month, and then if they wanted to add their family to it, it'd be a minimal cost. But I can tell you, the insurance for a family plan for Blue Cross is what is it, Mr. Bates, a month on average if you have good
About
health?
$1,100 the last I
$1,100.
looked.
So they'd be paying the $150 minus, you know, so if they had four in their family, they'd be paying $450 versus $1,100. Is that not correct?
Okay. What let's, what I'm gonna propose is that we allow, people one to go ahead and finish showing your comparison, to Marathon, and then we're gonna allow Marathon to come and share.
One quick question.
All right.
You did say that anyone off the street, it wouldn't necessarily be a school board employee can walk into People One.
That is correct.
Okay.
Yes.
Become a member.
They can become a member. That's right.
Okay. That's all.
That's correct.
That was
Okay, all right.
But it's very, it's not like, Express Medical where you don't have to be a member. You walk in and you wait an hour or whatever, and you get whoever's there to see. In this case, you commit to paying that $150. The contract's what, on a yearly basis?
No, it is a month to month. This is a model. This isn't like we got you healthcare, like healthcare is now. This is healthcare that is here to care for you and your family, provide exceptional care. And if at any point this isn't right for you, you step away and nobody pays. The school district doesn't pay anymore. The individuals don't pay anymore. This is healthcare where we have to show you the value and care for you exceptionally. Just to that point, I just brought this quickly. We've been open for about two months. If you went on Google and look at the reviews, this is the story, everybody. Yes, this will save the district and your people money, but that is the side story. If you went on Google and read these stories, this is about people saying, I finally have access to care. I had an hour with my physician. I was able to get the care they needed. I haven't seen a doctor in 5 years. This is the story of what we're trying to bring to your people in your community, because this is the care that they deserve. And sorry for the soapbox moment, but that's why we're doing this.
Okay. Yes.
Well, not a question for him, but just for the board, I mean, we've been dealing with this for 2 years, and this is it's been almost 18 months since their last presentation. And, I'd like, after the gentleman finishes, that, since none of us are experts on insurance, we have our experts here who guide us, and Mr. Bates and Mr. Bates, have them come up and just give a little bit of overview and a history, since they've been working on this long before many of us were even on the board. And then you can have Marathon come
Well,
up.
and I'd like to suggest that we have members of the insurance committee who
Sure.
definitely are the ones that we
Yes.
count
I have a
on that
question
are
for
in
him.
that position.
I did remember trying to do this 25 years ago, 20 plus years ago, to try to partner with the county and do a plan of this type, but we never could quite bring it to fruition. I don't know that the plan would have included the entire public that we talked about, but I mean, a plan's better than no plan, and a bad start's better than no start. So, I mean, we're here today to see where we are, to try to make a decision on what we feel like is best for our employees. And if it helps others and unites us with the county, that's fine. But I did hear prior to the meeting that the county really isn't behind this. This is a strictly private venture, but which is not bad. That's just for me to clarify myself. But
Okay.
that's good.
Mrs. Wagner?
Just, you had said it's like a month-to-month type of thing, but, and I remember very clearly your first presentation here, and I actually was extremely impressed right off the bat. But I have also been on the insurance committee for the last quite a while, and they've been working on this way longer than I, and I'm sure they can express more of the process they've gone through, because I can say, having sat through these meetings, it's been painstakingly detailed. The questions that have been asked, the conversations that have been had have been enlightening for me, and actually made me feel really, really good. And I wanted Phil to understand this too. They thought of things that never even crossed my mind when it came to our employees and what might work best for them. It doesn't matter me sitting up here, what it might help me, or it's our every single employee we have. So, but one thing you mentioned was that it's like a month to month. So if they choose that it's not right for them, but I can tell you what I think would happen if we offer it to every employee, they'd be fools to not say, sure, I opt in, because they're not paying for it. We are. And then there would have to be some sort of mechanism to where if they're not using it, we drop them.
Oh, yes.
Because I wouldn't want the money being, if it was my money, I wouldn't want it being spent on somebody who's just like, yeah, I got this, but I don't need it, and so we don't use it. 'Cause
Absolutely.
that would be wasted money.
Yes.
Maybe in the big scheme of things, it would still be productive, but that would be one of my concerns. And I just say, I mean, one of the good things, and I brought that up at our insurance meetings, I like the idea of doctors. I said at our meeting, I'm getting older, I just had a heart attack. I like the MD after the name, and that was, for me personally, that's important. But I also remember when I was raising my children, I had no insurance at all, so I didn't care as long as they could see him and write him a prescription. So there's a lot to be said either direction on that, but cost is going to be a big factor. I mean, there's multiple factors, and you've touched base, so I'll be quiet for now.
And I'll wrap up with that financial part of it, because you are taking a leap of faith right on that part of it. So let me give you a couple pieces. First piece of it is that, to your point, for many of our partners, if there's a standard put in place, and you all can say, but if you don't use this in 6 months or whatnot, your membership's paused, because if you're not using this and getting it, it's not an effective use of the taxpayer dollars. So putting kind of parameters around that is perfectly logical. A lot of our partners do that. Also, for your peace of mind, it tends to be about 30-40% of folks in year one tend to adopt, because a lot of folks watch. They want to see what's going to go on there. Are they going to get good care there? So you very likely won't have this wave of 100% of your folks. But if you got this enormous wave, there should be utilization kind of requirements around it, because if you're not using it, there's no reason to pay for it. My last point is up here. You won't be our first experiment with school districts. We have numerous school districts, both across this state and in Pennsylvania. We've driven 30% reductions in total cost of care. Osceola County was about a $60 million reduction. Orange County Public Schools is a newer partner. But underpinning all of this is, the last point here, is a performance guarantee. So we will put a contractual performance guarantee that for every dollar you invest from your health plan into People One Health memberships for your folks, we will return that back to you in lower total cost of care. So you don't have to take the leap of faith and hope this works. We'll have a contractual performance guarantee, and then you can watch the numbers and make sure that all plays out. I think that's all I had, but happy to answer any other questions for y'all.
Okay. Any further questions? All right.
Thank you so much.
Not at this time.
All right.
Thank you.
And we reserve the right to call you back.
I'll be here as long as you need. Thank you so much.
All right,
Sounds
at
like
this time, we're gonna go ahead and allow Marathon, if you will come, and then we will hear from the insurance committee.
Thank you, board, for letting us come today. I wasn't exactly sure if we were going to be speaking, sorry. I do have some printed out copies of the last presentation that we'd given to your Insurance Benefits Committee, which led to their recommendation to Marathon Health. Would it be acceptable to pass around some of the presentation material? Okay, thank you.
Thank you.
I think I've got a copy of everything.
I knew you were on the
Thank you.
committee.
No, we have.
Well, this is a little different, maybe. Same stuff.
And is it possible, well, I guess we could leave some of this stuff up onto the screen. This is probably actually a good summary slide, as People's One has described their program against the Marathon Health program. So why don't I just hit the slide directly, since it's up on the screen, about how our services summarize compared to theirs. The first point I wanted to make is that we also offer care to age 2 and above. So there was a comment about that as maybe being a differentiator, but that is not a differentiator. It's age 2 and above. Significant savings to members. We are also offering that, and there's information in here in our deck. Let me see, what else do we have on here? Partnership for Growth, performance guarantee. I think that is a good one that they have pointed out. I also like to point out that we do have a performance guarantee as well. And we customize these down to the elements that are specifically important to a group like yourselves. It is on the last 2 slides there, Marathon Health Performance Guarantee. And what I love to point out about that is that, as in everything that we offer at Marathon Health, we tailor it and customize it to you all at the school district. So in regard to a performance guarantee, we imagine that you would want to have some say in what you feel are the most important elements and how to measure it, what periods to measure it off of, and what items you would like to have us perform as a performance guarantee. But with that said, can I escape out of this screen? Yes. Okay, how do I do that? Just, let's see, exit.
We need Mike, someone to step over there.
There we go.
He got it. She got it, Thomas.
I got it. Not as bad at this as I think. So leading up to the meetings with the committee, and a lot of, back and forth information, of course, working and gathering. Oh, am I okay? Okay. Gathering information from your consultant. This has been a process, as we all know. And we came to you on the committee on June 20th with our last presentation. And we first wanted to make sure we were aligned on the goals of your organization. And so on slide 2 of our presentation, we talk a little bit about the goals. And what we had heard from your committee and on your behalf at the board is that you were specifically looking to support your members, your staff here at the school district. That is your utmost priority, and their health, their wellness, longevity, the retention of your staff, the attraction of your staff, all those things seem to be of the utmost importance. And so we also knew that you wanted to align on quality healthcare. You also were looking for some savings to your health plan. Things that we also noted in the process were the fact that you wanted to have a say in the services that are being provided to you, that level of control and tailoring to what your specific needs were things that were discussed often. And then, of course, the price, the methods, the fact that you could have a say in the cultural fit of staff that would be hired for you. All those things were coming into play, even selecting hours. I know there's been a little bit of conversation around a location. So some information was being discussed about those potential locations and perhaps having it on site. How do other school districts do that? On slide number 3 of our presentation, we talked about our experience from the past, and a great deal of questions were coming to us from your committee about how are other public sector organizations, specifically education sector clients, handling these aspects across the country? How are they handling it in Florida? You can see on our slide there that, we've been in business for 18 years in the state. We have 70 nationwide education clients. We have 22 public sector clients here in Florida, and we're up to 32 clients total. Our most recent client is only a county or so south of you, which is Flagler County Schools. We're in implementation with them right this minute. And each one of our school districts that we work with, we treat them very uniquely, as we should, and try to recognize what it is your goals are that you're trying to achieve, and then also what model fits those. In many instances, it is the on-site health center with maybe some repurposed space. In other instances, it may be a modular scenario. That's what our St. Johns County School District is doing. They're actually doing a couple blended scenarios where they have some modular on property that they own, and then they also have a repurposed building that they own.
Can I ask a question?
Yes, sir.
So you pay for that, or the St. Johns County School District pays for
They
that?
had building space that they were already supporting, and so it was an easy idea to them to convert it and to have it used for this type of purpose. For health center purposes. It was super important to them because they wanted to keep their access very close to home, where their staff members would be, and it would be highly utilized, high engagement, and no barriers to care. They also felt that the fact that they could get the well, I just said basically the main reasons.
Do you know what the cost was to convert any of those buildings to a medical facility?
It's been quite a few years. We've been working with them, I mean, since the 20-teens. So I'd have to go, or you could probably ask them a little bit about it.
So you don't have any idea of what the cost of conversion of
Oh,
just a building?
sure. So we're right now in the implementation phases with other clients who are choosing. And there's a range per square foot. It's actually in the contract too that has been presented to the board for approval. We do have a budgeted or allocated dollar amount that it would cost to convert a particular space that's being considered here in your own school district.
Now, then all that cost would be on the district.
It's clearly listed in the contract, and yes, a conversion of your own building that you're going to own forever would be a capital outlay of the school district for the choice to convert it to this purpose. All right. Would you like me to continue a little bit?
Yes.
Okay. So after these decisions were made about the potential location, why it's so important to have access to your school district particularly, and to have that level of control and that level of tailoring of services. We then explored on, slide 14 or 4 here, what kind of services would we be providing? And I know that the gentleman with People's One talked a lot about what are some perceived differentiators between our organization and theirs. And he started out by describing the direct primary care and saying that that's an equal level of care between our organizations. And direct primary care may be an equal level, but I really do believe it comes down to the individuals that you hire, the cultural fit, the hours that you select, the location of that access. But even if we were to say that that is equal, he went on in his presentation to talk a little bit about the integrated care team and that being a differentiator for theirs, and the service partner network. And actually, those aren't differentiators because we also offer integrated care teams. We have a very robust amount of staff, over 180 here in the state of Florida. And then we have over 1,000, in our corporate organization. So the integrated care team is something that you would also benefit from under our model. And then the service, I think he calls it service partner network items, where say you want physical therapy and you want the MRI conducted, or you need some specialty care. We can also offer these service partner network arrangements. And we're actually offering them at other school districts, like our another one that I have recently gone into contract with and is implementing with us is Lake County School District. And it was really important to them to have the mental health aspects available inside their center, both in person and virtually. And then they also integrated the physical therapy network arrangement. So very, very similar to what he's describing, is completely available with our organization as well.
Okay, we have another question, and
Yes,
then
ma'am.
you, Mrs. Pickens.
Yes, ma'am.
So you're saying that, I just had an MRI on my back, $250 out of pocket cost, and I'm on, insurance. And had I been on this, it wouldn't have cost me anything on their program. So you're saying everything that they're offering that comes in within the cost that our employees would be paying, that you will now cover?
To be honest with you, sir, I haven't examined in detail
Well,
their
MRI,
contract or their
X-rays.
particular offering. So I can't speak to that as to a cost comparison on what that particular network arrangement is. I would have to come back to you.
I'm not talking
Yep.
about cost in comparison. I'm just saying they're offering these services that you currently don't without an additional cost to our employees. I'm asking, are you willing, Marathon, to do the same thing? Offer those services to our employees at zero cost?
I would have to go back and look at these network specialty arrangements, but I'd also enjoy looking at theirs as well.
That was my question.
Okay, all right, and that took care of Mrs. Pickens' question.
Okay, very good. And should I move along, or is there any other question? Okay. So on the slide regarding the complete care, you can see what all the items are that are offered inside the centers, and the lab work. I think there were questions about lab work, quick labs, medication dispensing. All of those items would be available inside our center, as well as the mental health triaging on-site, after-hours triage line, value-driven referrals. Those, I think we categorize them in different categories than People's One does, but are included services with us. And I think there was some talk a little bit about a specialty connection between your primary care provider in our model and making a connection to a specialty provider. We also offer that technology, and it's incredible because you're in the same room, you're doing these type of consultation, and the gentleman with People's One was describing a similar service that we often and always enact when we need to have that specialty consultation performed. Support teams, I love to talk a little bit more about this. We have a very robust support team. We perform a lot of quarterly and monthly reporting. All the portal, the app, the technology is there for you. Scheduling appointments online, same day. All of those features can be offered to you. We have a education leader who is a former superintendent. Quite a robust clinical staffing team. Someone mentioned an importance of a physician-led model. We do have plenty of physicians here in the state of Florida, and you would always have a physician as the collaborating and supervising physician, even if you make the choice of having the mid-level individuals inside your health center, as well as different types of staffing. Everything is customizable and cultural fit to your organization. The other slides here, we talk about our personalized approach to engagement. I think this is super important because what I've heard is that in order to get to the greatest return on investment for your organization, we need the most individuals engaged. And the most individuals engaged would mean a thorough and robust marketing plan. It would be grassroots efforts. It would be going, to different staffing meetings, engaging your leadership, and taking all the different cultural approaches that would best suit your organization. And so when you engage more and more members, then this creates a great deal of patient success. And it creates a scenario of less high claimants in the future, less ER visits, and it saves lives. So I've heard all those things as the goals of the organization, and we're here to deliver, and what we are delivering for others in the community. Now, the next thing I wanted to point out too is I heard some things about the fact that the model you're also comparing and contrasting right now is open to the community or open to other providers. In the model that we're offering to you, it would be solely based around only the needs of your school district, and you'd have complete control over it. Certainly not open to the public, certainly not open to other employers, unless you choose to allow another employer to have access to your dedicated health center. And frankly, this is the way most of the school districts that I work with in Florida and around the country choose to implement services of this nature. They want it solely for the benefit of their districts.
Do you know, excuse me,
Yes, sir.
if in some of the other Florida school districts you serve, do they allow not just the public school system employees that you're contracted with, but do they allow homeschool teachers and their families, or charter school people and their families, or I just was curious how big a broad umbrella that is, with not that these are not bargaining unit people, but as far as education, just a curiosity.
Would those individuals be on your health plan, would be my question, and if they are not,
Strictly
usually
health
they
plan.
do not.
This isn't, it
yeah.
is strictly our employees and not open to just,
Yeah.
like the People One plan is open to the whole community. Okay, I got you. Okay.
Yeah, most choose to allow the individuals that are on your health plan because those are the individuals who, you're going to see in your claims files, you're going to see in the rising cost of healthcare being provided. I do have some school districts who choose to offer those on their file, and they decide to pay for them, even though they might be part-time or not eligible for benefits in some way. They're choices that can be made if there is the financial ability to make them. One of the things that we stride ourselves on at Marathon Health is to be ultra fiscally responsible in any option that we offer to you. And we don't want to sell you on things that maybe you don't need immediately. So one of the things that often happens, and you can see I have a slide on a pricing overview in here, is that we try not to overstaff your centers from the beginning with too many or bells and whistles or too many extra staff members to what your initial needs might be. We recognize that the goal of the organization is to get as many people using this as possible, to give them greater access to curb high claimants and to give them a vehicle of chronic condition management and mind and body well-being. And we also know that that takes a little bit of time before the engagement picks up. But if you're like most of the school districts that we work with, you're going to see, around 50% of your membership using your center even in the first year. And year after year, that's going to climb and climb and climb. And so we staff the model based around, it doesn't matter if, you have only 300, 600, or 1,000 individuals, members using it. We're not charging more unless you get to the point where there's, say, 1,200, 1,500 members consistently using it, and the schedule is getting blocked out all the time. And then at that point, we come to you and we consultatively discuss that this is what we're noticing. They're just using it more and more, which is exactly what we all want them to do. And it would be probably a right time to hire another provider or to hire another nurse. And for that value, you may have a few $100,000 more for that person, but it's not charged like on a per 150 per person or anything of that nature.
Mr. Leary.
So we've had a declining enrollment in this county for years, and I don't think that's going to stop anytime soon. Subsequently, we don't have our employment, our employees are not increasing. They're either staying kind of stable or in cases we continue to see a decline, that we'll lose employees. So your scenario of building more, I don't think would apply to our district and may not apply to many rural districts like it would in Orange County or Osceola or one of the, Miami-Dade, one of those counties that's continually growing. Would you agree with that?
I'm not exactly sure what you mean in that question, because
We were saying that we would grow as, you know, as we grow, there'd be more employees that would take advantage of our facility and, you know, this operation would all be under the district. Well, what if it was declining?
Yes, the question that you're asking me is, I'm not suggesting that you might have more and more employees. I'm basing my recommendation on years of books of business of educational clients that after year, more and more of the current membership, the current staff, and their dependents that you have already enrolled on your plans, or that you're hiring in as new hires, are going to take more and more advantage and engagement of your health center, which is going to cause more, more appointment usage and more engaged members year after year.
Okay, and also going back to, you were saying that, you know, on the staffing of the facility, you don't have a doctor there, you just have a ANRP or a PA, and then you were saying that, you know, you would staff up if you needed additional staff, if it would grow.
If it never grows, then you won't be staffing up at all. But the growth would be in more and more appointments coming in and more engagement of your membership coming in, which is, I believe, an aligned goal between committee and board, is to have as many of your members using the center as possible.
Well, specifically the ones that don't have insurance, for sure. Yeah.
I sit here trying to think and see the mindset of the district, of our responsibility for the employees. Number one, to make it affordable. Absolutely. Then accessible, making it accessible to all. Then with those things being in place, I, in my mind, see our employees coming to work. Wherein if they are healthy and their family is healthy, we won't have as many out taking days because they're sick or because someone is sick. We are then able to put a handle on these sicknesses early enough that it does not progress into something far worse. That's what I envision the whole program presenting for our employees. Somewhere immediately they can go get these things taken care of, and as Barney Fife would say, nip it in the bud. You know, get it early enough that we can do it, and making sure that it is there, because we've even talked about, as we get this moving, looking at the west end of our district and the south end, so that we can cut back on travel as to where they would have to, go to get these services.
I think along what you said, Chairwoman, that was so well spoken, is when you have your own center and it's only available to the members of the school district here, you have that greatest control. You would never want to wait to get your own person, in when they need to get back into your classroom and on with the role of teaching your students. Have to wait because maybe that appointment slot was being taken by a county member, or maybe it was being taken by, a community member, even somebody that's in the community. When it's a dedicated center to just your own, there's nobody else's priority going on there other than your own and your staff members to get them in the door and on to other items they need to basically provide the best services they can here to your school district.
I see benefit to both plans. I see the benefit educationally of not having someone ahead of our bargaining unit people and our employees that we serve, and that we're truly, our insurance committee has, at our request, has been trying to bring us some type of solution for quite some time. And I know I sound like I over dramatize things, but I have seen, I remember one particular maintenance employee that had a bad stomach ache and didn't feel like going to the hospital because he couldn't afford it, and wound up dying overnight when his strangulated intestine burst, and he died in about 13, 14 minutes. So, you know, we want to serve our people and do it in a manner that is feasible and top-notch. And I listened to the comment on the west end and the south end. I want to find a way to serve everybody, you know, make it available, but I don't know, just, I like what I see in both plans, but I just don't yet know how many people how crowded that's gonna be right now, and
Well, they've got the time in their proposal. I mean, you have a specific time that you spend with each client and the time
Well,
frame which they have
yeah.
to wait to get in. So
I'm sure they're gonna
all
be
that's covered.
top notch and professional, what I hear from Marathon is good too. I just,
Finish and
I-
then
but I'm done, y'all can
Okay.
keep talking.
Yes, yes.
Go ahead.
Sure. I just wanted to point out that one of the key elements I think that makes our model different than what you're examining with People's One is just the fact that there's a charge for the exact thing that you're trying to accomplish the most, which is more engaged members using healthcare. In their model, it's a charge. It's $150 a person. I think I heard $450 if there's a family. That adds up considerably, and that's just not the same model that we're operating under. And you can have, in our model, I gave you the example of 1,000 people, which you have about 1,000 people on your plan, and every one of them we want to come in. We're going to be trying our hardest to get these individuals to come in and seek this healthcare, use this healthcare that you're supporting there at the school district. And you're not going to be paying additional expenses here at the district for that. On their side, I mean, it's more than double if the same 1,000 people were using the healthcare. And whether that were people that are on the insurance plan or not on the insurance plan doesn't even matter. The same 1,000 people would be more than double if you just added up on the per person per month scenario. And so the last couple things that I described in my presentation and the committee reviewed towards their recommendation to the board was just what's all included in the fixed fee, and that's listed there, and then the performance guarantee. So I appreciate my time.
Question?
So the
Yes,
fixed-
ma'am.
what, and I'm confused, the per person cost, per employee cost for you, which would be paid by, what is that on a year?
We're actually on a monthly fixed pricing, sir.
How much is that?
The monthly fixed pricing for the model that we have offered,
Which doesn't include all those x-rays, MRIs, any of those other things. It's just, but it does include children from 2 to 12, correct?
it does. And if you want to re-examine, it's a very robust scope of service. There's a snapshot of it on the complete care slide inside your proposal, all the way from mental health to the labs to the value-driven referrals, which they call the integrated care teams. The service partner network is what they call. We have different labels for things, but everything is listed on here. And we have a monthly fee of $55,803 is what's listed for the staffing model that we've presented with the one provider and the 2 assistants. And that doesn't change until the schedule maxes out. The laboratory, someone had asked me in committee, and I'd gotten it in advance. The average laboratory costs they're just passed through as used, because again, we don't want to charge you for anything that you may or may not be using. Those usually average around $7 or so a lab. Medications are usually around 10 or less a medication. You only pay for something that is being used in our model, and it's just a philosophy of transparency, flexibility, customization, and tailorization, along with you at the school district having ultimate control.
Okay.
Thank you so much for your time.
So as I'm looking on this, I guess it's the third page from the last in the handout. It's Your cost per member, it says $150.
No, that's theirs.
That's theirs. Okay.
That's-
What, and
that's
so where is
people
your
one.
cost?
No, that's a per member per month, which would be people one. This side would be Marathon.
All right, yours
Over
is
here, yeah.
669,630 for up to 300 people
Per year.
per year. Okay.
That is right, because we do not budget, the staffing model and the health center model that we're presenting to you is not based on how many unique individuals use the center. It's just based on capacity. Until you max out that schedule, you can have as many individuals using it as you want.
Okay, and so the staffing would be one, there'd be a doctor there and two.
There would be a
nurses?
provider there. We always,
What is a
we always have a, I think you had asked the question about a physician-led model. We always have a physician-led model. It's a local Florida collaborating and supervising physician. And then we would have an advanced practice provider, that's what they call it, for a nurse practitioner or a physician's assistant. And we would also have the medical assistant supporting the provider, in this case, either a nurse practitioner or a physician assistant, yeah.
Okay, so you, according to this, you'd have a nurse practitioner or physician assistant one, and then two medical assistants. Is that correct?
In the model that is being suggested to you, we also have the ability to customize models to have a medical doctor or a number of other staff members. So, yeah, I think you understand
That
it.
increase the cost, or if we ask for that in the model?
I think that you'd probably want to ask your insurance committee to have models rerun or something if that were a question that is being addressed or asked.
So you can't answer it.
No, I'm sorry, I can always offer plenty of different models for you.
She,
But the
But the
cost would be
key-
different?
okay, oh, I'm sorry. Two of us are talking and he had the
ahead,
floor.
Madam Chair.
I apologize.
I'm sorry.
Go ahead.
No, no. So the model would be, the models are different. Does it increase the cost, or is it all based on your fixed pricing?
May I repeat the question to make sure I understand it? Okay, I think what you're asking me is if we changed a nurse practitioner or a physician's assistant to a medical doctor in this model, would it change the price? Yes, sir, it would change the price. The reason why is a medical doctor costs quite a bit more than an individual at, a nurse practitioner or a physician's assistant. Probably wouldn't change it ridiculously more, but there would be a change of price to add for that staffing expense.
Madam Chairman, so to me, it's not apples to apples, and that's why when we finish our discussion and she finishes her discussion, I would like our insurance consultants to come up, and I want their opinion because they're the experts.
All right, we're gonna hear from them. We are, I think you're set to go next, am I correct?
Whatever the
Okay.
pleasure of the board.
Okay, all right.
Thank you.
Thank you so much. I was gonna ask something, but it'll come up later.
We're gonna hear from the insurance committee before we hear from Mr.
Good.
Bates.
Okay.
Sandy,
Well-
let me ask you a question. It's been an hour and 7 minutes. Could we take a 5-minute break or 3-minute break and come back, or
But we,
if it's not necessary? That's up
no,
to
no, yes.
uh,
Let's just take a 5
you.
minute.
Gotta go somewhere.
Just a 5 minute. We're gonna go ahead and reconvene. At this time, we will call Mr. Bates. And Mr. Bates, if you will come, you've heard both, and we will hear your summary or your overview, and then we will ask questions.
Thank you. Couple things I'll point out, just so we're clear. Either of these models do not replace traditional insurance. They are excellent supplements. Lab work, seeing a doctor, MRIs, depending on the model, physical therapy, both these models handle. What they don't do is obviously your hospitalization, your cancer. So still that blanket, that traditional comprehensive insurance is needed in both models. What they do is they handle accessibility. I think in particular in Putnam County, the number of doctors we have is limited. You drive around, we're seeing, and this is, I mean, we're seeing more burnout in the healthcare profession. It's beating many other professions out there. So we're seeing doctors, they're getting bought by larger practices. Some are leaving the community. Accessibility is an issue. So both of these do address that, which is a positive, and it is greatly needed in this community when you drive around. Speaking a little bit, did want to talk just for a second about eligibility. I think when we looked at this, the goal was for these either option to be available to those enrolled on the healthcare plan. I would be a little potentially to open this up to everyone with the current insurance fund, the current funding. That would scare me personally. I don't know about others. Now, if we want to look for additional funding, where if there's additional funding that can come in to supplement this, to help pay for that, I think everyone would be in agreement with that. Because when we look at affordability, the district does $450 per month, and then there's an MOU, so that's $630 per month total contributed to the healthcare plan. Am I correct in that?
After you walked away, I think it's 680.
680. So when we look at these models, I believe we had looked at it, looking at the eligibility of those that are enrolled on the healthcare plan to supplement that plan. Opening up that to everyone that's a district employee without any additional funding. I think when we run the models, we're going to deplete that insurance reserve rather quickly.
Can I ask a question?
It's a $3 million cost. So, I mean, yeah.
So I just had a question, and I'm not trying to sway either way or advocate, but is it the idea to pay for the district's portion of this from your insurance fund?
For those, when we look at it, those that are eligible employees that have health insurance, then those monies would be paid for from the district insurance fund. For those already on the healthcare plan that are working and contributing premiums towards whatever plan they have.
How about the $650,000 plus or minus that would be upfront charges under the marathon plan? Because you've got a.
Well, that's more of, I think, a board. Does that come out of the insurance fund? Is there additional capital outlay? I mean,
That's what I was asking.
ideally it'd maybe come out of capital outlay or something. I mean, I guess it could come out of the insurance fund, but that's more of, I think, of a board.
So it's 687,000 to,
Well, the annual fee was whatever it was, but then you've got the. You've got, the annual fee is the $669. But then you have, I believe, about $170,000 for equipment, furnishings. Am I close? No. Close. Well, it's about $650,000 total when you add in all of the costs there. And those are estimates. It says that if the actual costs exceed that, then the district's gonna pay the actual cost. But the building, equipment, I guess it's equipment cost was, so you've got $171,615 as an implementation fee, $19,845 as a construction management fee, architectural design fee of $25,000, and then the build-out costs for the building, $441,000 more. So that's in excess of whatever it is, $660,000-$70,000 to get started. And it indicates, and I'm just, as the lawyer, I'm just mentioning the fact that this indicates that these are not hard and fast guarantees, these are estimates. As it says, actual build-out costs may differ from this estimate based upon actual bids. Invoices for build-out costs are payable in accordance with section 4.1. So it's on you. So if your estimated costs, I don't know where the 441 comes from. I don't know, you've recently had some issues with estimates and the actual bids coming in higher, but that number is, I was just simply asking, I hear where the fees would come from, the annual fees, but the build-out cost, that's 650, 60, 70,000, where does that come from? Mr. CFO.
Insurance.
You have capital outlay or insurance fund, and that would actually come down to probably a decision around the executive team, which one they would want to use capital outlay or not.
We don't have capital outlay. I mean, we're pretty maxed out with our costs for the 2 new schools, correct?
Well, you got insurance committee funding, but I mean, obviously,
It was to use, I'm sorry, go ahead, David.
you got insurance committee funding, and the reason I thought originally the county might be involved in this is, I mean, we could take like the senior center where we gave the county the property, they built the senior center, turn that into a facility close to the county building, but that's not an option now. This thing is going to be out there on, in a great location, but it's not like, the kind of what I had envisioned, maybe partnering with other employees, but that's not here nor there. Don has some good questions that I guess we need to continue with, so I'll hush.
I think the biggest question is, funding and cost to us, to the district, that it's apples and apples that we're comparing between the two different companies. And so I guess my question to you is in your analysis, of the two plans, the contracts, and Don can certainly talk about the contracts, are they equal? Or is one better than the other? Or where are we?
I think that's why we're here, because ultimately they are different. One is pure exclusivity. It is yours, you own it, you control it, you pay for all of it. The other is more of a community-based, where it's working with the community. It's accessible to other groups, and it's paid on a subscription service versus the other where it's a fixed cost. Obviously, you have your upfront costs, so you've got to build it with the build outlets Mr. Holmes mentioned. So there is and with the performance guarantee, the People One model, based on their pro forma, shows savings quicker, where with the Marathon, because of those upfront fees, it's a delayed in seeing those savings. Because you're building your facility, which you own. So there's pros to that. You own it, you can do something with it, but you own it, it comes with a cost. So, I think it's hard because they're very different. I think that's why we're here, because there's two different models. As you've heard how we fund them, one's on a subscription based, one's on a flat fee, plus some pass-through cost. So it's hard for me even to put them, because it's a different model.
Okay, so,
And after you're done, Mr. Superintendent had.
oh, I'm sorry,
Yeah,
go ahead.
question.
Rick.
No, I didn't, go ahead.
So,
I'm good.
The numbers that our board council came up with our first year, out-of-pocket costs would be about $1,326,000. And, I'll just say this, and I can tell you, we're not in the medical business here. We're in the education business. And, having these facilities and having to pay insurance on them and liability and the cost and everything, I think we have the protections for our employees in the People One model that guarantees they don't wait when they go in. They get their appointment, they're in. There's no minimum amount of time that they'll spend as much time the doctor will with them. So I think we're just not talking apples to apples, and based on, and Benji, you tell me if I'm wrong. On my analysis, financially, we're much better off with the People's One, and then I think medically, the benefits to having a doctor there, having the ability to, they work under contractual basis with other providers for, MRIs and physical therapy and all those things. It seems like it's a better model. I understand wanting to do it,
Yeah, no, it's one, as was shared, is physician driven. You have that option. We'd have to get that proposal to see how much more that would cost. And we looked at that, and it wasn't mind blowing, but it was some additional money. I don't want to scare. It wasn't that increase, but no, So they're two different models. At the end of the day, there's you can look at the implementation. One's ready to go, the other we have to build out. So I think the urgency of that is trying to get things going, because it does take time to build out a facility, hire the doctor. So again, but bravo, I mean, I think bravo to the committee and everybody to get to this point. And we've been, you know, it's there, but it's hard for me to exactly, because I see pros and cons in both. I think ultimately it's kind of based on which direction does the district want to go. Do you want to own one thing, put up the upfront costs to have that for the long term, or do the subscription based? And I think that's one thing, even looking at it, the contract. What was did they give you, was it a 60-day, the out clause, and the people one?
People one, I didn't
Okay.
see the people one contract until today. I think it might have been sent to me, but I didn't know about the people one contract being considered today. There was no out clause in the original Marathon contract, but when we had met to talk about a few things that were not originally in it, I understood that they were putting something in here now for an opt-out. Let me see if I can find it real quickly. Maybe the Marathon representative could tell me where that is so that I don't have to search through this whole thing. Is there an early termination clause in here now?
Oh, there were a number of edits, sir, that you asked for, and we agreed to everything you asked for. I don't have the contract in front of me, I'm sorry.
All right, so let me see if I can find it real
But
quick then.
any edits that you had asked for, we had accepted.
Okay, here's term and termination. That's the addendum only.
Well, Phil's got a point. I mean, we're not in the medical business. I understand that. Although we wind up with, you know, Narcan and kits to, you know, bring your heart back to beating and everything else in our schools. We're kind of tied into that reality. I think we're kind of boiling down now into what to me would be almost a collective bargaining type agreement between what our employees would want compared to what, and I'm not saying we're in collective bargaining right now, but it's been a long time since your reps used to go back and have the employees here and let the board know, but I don't know, maybe at some point it's something that might need to be done, because I mean, we can arbitrarily decide and it may not be, you know, it may, either way may go wrong. I don't know.
Yes.
I found the terms of note. Would that help you if you look on my computer?
No, I'm looking at well, I guess this is the latest version of the contract, and it just, at 7.1 has the termination provision in the contract that I'm looking at. There is no, on this version, there is no voluntary termination. There's termination in the event of default and failure to cure within 30 days. But I don't see a voluntary opt-out provision here, unless there's something. This is under Article 7 termination, and the only two bases for termination would be event of a default and failure to cure within 30 days. So otherwise it'd be looks like it's
I looked on the terms of note which guided that discussion we had, and correct, point 4 was a 5-year agreement.
right. I mean, when we were discussing it, it was a longer term agreement, and let me see if it says term. Now it's, go back and look, but initial term of this agreement is 3 years. So the term now is 3 years with automatic renewals of 1 year each. On the renewals, either party could terminate not less than 90 days prior to the expiration of the current term on the renewals. But on the initial term, it doesn't, I don't see a opt-out for the first 3 years.
Either option's good.
But
I
you
mean,
haven't had time, I mean, obviously, we just got the people one today,
No.
so comparing contracts is,
Can we,
right now.
Yeah, I haven't looked
I'd
at
still
the
like to
people's
hear
one
from the
until
committee.
Yeah,
I think we still
let's-
need to hear from.
they're the ones that know.
they're the ones that,
Yeah.
I just,
I think we really need, and well, Benji is
'Cause I see
obviously
heads-
on there, but
some heads agree when
guys
I
know.
say things, some shake their heads. I just want to know kind of what page our employees are on, so we're not just, I mean, I love either idea. I want to do what's best for our employees and what they really need and want. And like I say, People One is great, Marathon is great. I like the options, but I need to hear from you guys.
Benji's going.
And Benji, we'll bring Benji back.
Sorry. Oh,
She had a question.
oh, yes, ma'am.
No, I want you to finish.
Okay.
I think you were interrupted.
Oh, no, I just know, like I said, looking at it, one, 3-year term, the other was People One, I think was a 60, what was the opt-out? 60-day for convenience. So that was one difference that I saw, with that. And then, yeah, I mean, again, when we go back to accessible, this is going to be a win for our community. I can tell you, our emergency room sees 3,500 people per month. 3,500 people go through the emergency room per month. Many of them don't need to be there. Why are they going there? Because there aren't options. So we are, with this, working to solve the accessibility. Being able to offer this to the employees on the healthcare plan at no additional cost helps those that are on the plan with affordability. I think there's work to be done if we want to expand this for others. It comes back to funding. Additional funding can help the expanse of this. But I think when we looked at this all along, we were looking to do this for those that were already enrolled in the healthcare plan, paying premiums, because again, it's going to supplement that. But again, it doesn't replace that traditional healthcare plan. So if they have their Blue Cross for now, if it changes, that means if they get a cancer diagnosis, we can get them into Mayo, we can get them into North Florida, we can do that. Opening this up to everybody where it gives them more accessibility. If they did get that, then they would not have that catastrophic coverage. So we'd be working to fill those gaps with an individual, other things like that.
But they can.
You can,
individually join
They on their own dollar, they can join.
for $150 a month.
They can join on their own. I think you could do it in a way. So I believe I think this is ultimately, it's really up to y'all how you do eligibility. What you could do, and what I've seen some other groups in the county do, is you're on our health. So I'm an employee of the school district. I do individual only. That's paid for through the insurance fund because I'm contributing my premiums. I can then opt in and payroll deduct the $150 for my employees if you guys are willing. That's more of a district eligibility decision. I've seen another private employer in this community do that. They open, if you're not on our health plan, then you're going to pay for it and we're willing to payroll deduct it. That's more of a finance decision, internal decision, because that's additional work on your staff, your resources. But I did just want to share with you what others in the community have done. And what we have, and most employers in Putnam County that have signed up with People One have done that. It's a benefit to their existing, it's a supplement to their existing healthcare plan. And I think either option, that would be my recommendation to go, as we, at least try not to, I just don't want to get it too big and try to solve too many problems with the limited funding that we do have currently.
Does the People's One contract have a requirement that the district maintain insurance? I'm asking, I don't know.
No.
No? So then my next question to you would be, and has this been taken into account? And I'm just looking at this as I would if a client said, hey, look at this and tell me what my risk could be. The Marathon contract does have a requirement of you maintaining insurance. General liability insurance covering clients' business operations on the premises. So that means your facility that you're going to be building, you're going to maintain, that's what it says, general liability insurance covering clients' business operations on the premises in which Marathon services will be performed. So that's liability. I would assume that's premises liability and not, some kind of E&O malpractice coverage, but I don't know. General liability. Property and casualty insurance coverage for all of clients' real and personal property to which Marathon and its employees are granted access or given use to its full or depreciated value at client's option to include but not be limited to insurance on space needed by Marathon for the performance of its obligations under this agreement and all clients' infrastructure and improvements, which you may already be carrying. You may already be carrying that as part of your plan. Other insurance typically maintained within client's industry. I don't know what that is. I don't know what other insurance typically maintained is. And then you've got the waivers of subrogation and the clause that states that neither party be liable to the other for various damages. So my question was, in looking at this, I don't know if you looked at this from an insurance perspective, but my question is there an insurance? And the thing that, you know, as a lawyer that comes to my mind is, if somebody goes and gets treatment at a Marathon facility, Marathon's operational our facility, and there's a claim of malpractice. Do we have insurance to cover that, or are we gonna have to buy insurance to cover that?
May
I-
I answer that one?
Sure.
Okay. So I think you brought up a good point, but not having the exact contract in front of me right now, you will notice there is insurance that Marathon Health is providing inside your contract too. We provide all the malpractice insurance. We provide general liability, commercial liability, umbrella policy even in aggregate. So the premise of the building, it being your owned building, so your roof is your roof and your structure is your structure. But the moment that an individual steps through those four walls and into the door of the building, anything related to the insurance claim is on us as that happens. So whether it's a spill and fall, whether it's a malpractice, whether it's anything that's happening inside the four walls of the building, once you have that purposed for our purpose, our insurance is what is kicked in.
12.1, and I know you don't have it in front of you, but I see where there's an insurance clause, but then and I did have this underlined when I first reviewed the contract, because it states each party shall defend, indemnify, and hold harmless the other party. So from me looking at it selfishly from the district's point of view, the district's gonna hold you harmless, your subsidiaries and affiliated companies and their respective directors, officers, employees, and agents from and against all claims, causes of action, suits, losses, damages, reasonable attorney's fees and costs that arise directly from or out of any third-party claim asserted against any indemnified party, which would be you, alleging negligence by the indemnifying party, which I guess would be us. So we would hold you harmless for any claim that's asserted against us alleging negligence, right? That's what that says.
I'm not.
Any claim asserted against you that alleges that we were negligent in the district, we would hold you harmless from, right?
I'm not an attorney. I would love to take that back to my legal staff to make sure that I understand. But the most common scenario I could imagine is if a roof of the building wasn't maintained properly or something of that nature, and then maybe there was a co-claim scenario that was trying to happen because of it. But not being a legal professional or attorney myself, I'd like to, if we have further question or edits or something to that, I'd love to bring it
You could
back.
probably ask some of your other clients, you know, how they handle
Right.
that. You know what I'm saying?
Right.
You said you have other clients in the.
Absolutely.
So you could probably ask them
The
how they
majority of our
handle
clients have
collection of
on-site
these, 'cause, you know,
centers like this,
in today's
yes.
world, if a Marathon staff person is alleged to have committed malpractice, you guarantee we're gonna get sued. I mean, it's just a fact of life.
It's unfortunate that everyone ends up being sued in these cases too. Yes, and that's one of the reasons why they have they've been raising the limits on the malpractice, the liability, and the aggregate and umbrella policies and so forth that are listed inside the contract.
Would you,
Thank you.
could they get listed as additional name, would they be listed as additional named insured on that policy?
Usually, that's a common request. Or do you handle that side of it?
No,
too?
I'm
Or-
just,
oh,
I'm just
okay.
thinking, I mean,
Okay,
I'm
right.
just thinking of
Yeah.
if you have a policy,
Yeah, that'd be great.
that would be,
It's not in
I
here.
mean, that might be a
That might
quick
solve the
solution.
problem. So
That'd be great, yeah.
All
Yeah.
right.
So that's
All
an
right.
additional insured. This one requires $5 million of insurance. That used to be an unattainable level, but as we all know, it's not anymore when you have claims. But at least it'd be a lot of protection if we were listed as an additional insured on that policy. I agree.
That was just that was just a simple maybe fix.
Hey, I
Yeah,
appreciate that.
yeah.
Thank you so much.
Yeah, no, and like you said, I mean, I think on the property that would be is the look at that is what are the limits? Are they adequate? Because as you said, you know, what we used to think was $1 million. I mean, even in healthcare, you know, I mean, $1 million claim used to be. Now it's very common to see that. So one recommendation, additional named insured to get those provisions. And again, that just puts you on their policy and names you specifically. Yeah, good point.
Thank you. Any further questions from Mr. Bates at this time? And again, we may have others.
Oh,
for
please,
you.
yeah, I mean, yeah.
Yes, sir. Thank you. All right. Committee, let us hear from you, please.
Good afternoon, Board. So I want to address a couple things first, and then I want to talk to you about why I think Marathon's a better option and why the committee, I'll speak for the committee, and they can tell me if they say otherwise. But to address Mr. Lear's point of the we're not in the insurance business, and that's exactly why we would contract with Marathon, because they are. We set up the facility, and their insurance covers that side of it. They're the experts on that side of it.
So you don't think if we own the building and are responsible for everything with that building, that we're not in we're not in the insurance business too? I mean, I don't see how you separate the two. I mean, because they were saying everything's our responsibility, our building, we have complete control.
Yeah.
I
Right.
mean, that to me is, you're in the insurance business. I
No,
mean,
we're in the business, Mr. Leary, of trying to provide the best health care possible for our members of our school district here. That's what we're in the business of, and Marathon is the choice for that. Let me tell you why. So, apples to apples, you were talking earlier about that, Mr. Leary, and most of my points here kind of relative to things you've said. Apples to apples here. If you compare the cost of what People One's asking versus that $669,000, that works out to about $55,000 a month for Marathon, and that covers 366 employees with People One. So for that cost, all of our members of our insurance plan have access and are eligible to use the Marathon Clinic. All of them. All, how many, 900? Almost 1,000, okay? For that $669,000, for that for the $55,000 a month fee, $669,000 a year with Marathon, all of our employees that are on our group health insurance, almost 1,000 of them, have access and are eligible to utilize the health clinic. All of them.
Wouldn't that apply with People's One too?
No, not for the cost they're talking about, $540,000. For all 1,000 of for the same number, 1,000, that'd be $1.8 million a year for the same number of people to have access and eligibility to the People One Clinic. That's the apples and apples comparison. Yes, there are some things included in that $150 a month, but we've got to get to almost $1.2 million in difference to actually, make up for that. Pass-through claims on some prescription $7, $10 amoxicillin, or $5 Z-Pak, whatever. The blood work for $7. Those pass-through costs, those aren't at industry standard prices. Those are at cost. We don't pay premiums on that. That's what they cost to do. So we're saving on what the employees, all the services that are provided. Even if it is a pass-through cost to our insurance plan, it's way cheaper than sending that person out to Quest or to get blood work, or sending them to get a prescription somewhere else. The cost of whatever that is, that's what the group plan would pay. $1.8 million to cover 1,000 people is almost 3 times, more than 2 times the cost of the same number of people being eligible to use the health clinics for Marathon. That is the number one reason why Marathon is a better choice for us, because every single one of the employees that is on our group health plan would have access to those clinics, access to that clinic.
And they wouldn't, under the same scenario, have access to People One?
They would not. They would not, because we're not paying for all 1,000.
So we'd only be paying for?
I don't know. The model, the offer that's been made is for 300 people that would cost $540,000 a year. That's for 300 belly buttons to have access to People One. We have 1,000 people on the plan. So if we wanted all 1,000 of our folks, our belly buttons, to have access to People One, that would cost us $1.8 million a year.
Okay, how many people are not on the plan under our employment? Another 800?
About 700-ish, right? About 700. Yeah. That gets up to about $3 million, the kind of what you were discussing earlier about having all the employees having access to People One. That'd be like almost $3 million. And we certainly can't, the insurance reserve can't afford that. I think that, let me say that People One, I think that it is a great thing for our community that People One is here. Because for the small employers, to be able to provide some of the, but we are large enough that we can have our own clinic. And that leads me to reason number 2, okay? We don't have any control over that clinic. That's a clinic that is a community clinic. You know, the hiring and firing, the hours they're open, all that kind of stuff. We don't have any say in that. We pay our $150 a month, and it is what it is, right? But with our clinic, with Marathon, we decide. You mentioned PA versus MD. That's up to us to decide. You know, if it's worth the extra cost to us to have an MD, we can do that. You know, if we want to have imaging, then there are costs there, but we can. In Polk County, they have 3 clinics. One of them has imaging there. So if people need imaging, it might be a little longer drive to get to that clinic. Not all their clinics do. They have 3 clinics there, but one of them does have imaging, so it's an option. But they're a larger county. They got more people, so it's, you know, they spread that cost out over the more people.
Good question. So, why would y'all not want a doctor? You know,
Nobody said we don't want a doctor. I mean, that's a choice.
that wasn't in their model and what's in the contract, correct? I mean,
That's correct. Yeah.
Okay. So why, I mean, what was the rationale for that?
I think exactly what Ms. Wagner said earlier. Most of our employees at this point, they just want to see somebody that's going to help them get better. And, you
when
know,
combine that with the
absolutely.
cost
Yep.
differential.
The cost
whatever that
differential,
was.
you know, yeah. Now, if it was important to the employees of Putnam County School District that they had an MD, then we could do that. And I forget, Benji, I can't remember what the cost differential was on there. That's something we discussed in the committee. We talked about that.
If I recall correctly, we had actually had that conversation, because I was a big proponent of having a doctor, so.
Yeah. Ms. Wagner, she said, I'd rather have an MD, and so that's something we can do. The
it's-
proposal that
yeah,
was there.
They're very willing to say, you know,
Yeah.
you can start like this, and then as you identify your needs,
Mm-hmm.
and maybe where you don't need as much of this, or you do need more of that, that's what she's meaning by the customizable.
And that's the customizable, that's the
We get a lot
control
of
we
people
have.
saying, we want a doctor. We want a doctor, we don't want this PA, then we can go, okay, you know, and we do it. So that customizable part was a big,
And that customizable can be changed at any time. We don't have, during that 3-year contract period?
I'm not sure what kind of time limits, you know, how often or that kind of stuff, but it's up to, yeah.
Okay.
You
Yep.
can even tell us to change a staff member if a cultural fit isn't working out for you, and usually it takes a couple months of transition to the new staff member, but you're always in control.
If the customer satisfaction numbers aren't coming in right, because that's one of the things that we heard from Marathon that was a plus. And people may have had similar things, but the way that they follow up to make sure that the people that are going for those visits are completely satisfied with the care they've received, and following up on if there's any kind of little blip, any kind of little issue, following up on that and addressing it. You know, within 48 hours. I mean, there was some kind of 24, 48 hours, some kind of very quick response to if there's a, sorry.
In case we
Yeah,
get some side.
there was a very quick response time too, if there was any kind of negative feedback or something along those lines.
Mr. Modell, so some of you all will act, a group would act sort of like a board of directors, not, I don't want to call it overseers, but you're saying we get to change who's the we that gets to say, you know, that group.
That's the we. This
So
board,
that's what
this
I'm
board
talking
with the
about.
insurance committee as your
Okay,
agents
all
here,
right.
if we look at the feedback from the employees and they say, you know what, we really want an MD,
Well,
then
and
that's
that's
the
back-
direction we would go, you know?
Andy, that's back to my question,
Yeah.
and I mentioned probably inappropriately collective bargaining, but to me, it's having to figure out who in the bargaining unit that we're gonna deal with that's gonna deal with this, and how is the board gonna deal with this? It is different, and I know these other counties already have a working model to kind of watch and look at. I just need to see a little more of that, but I'm with you to where you're going right now.
Kind of along those lines, Mr. Buckles, in the process of all this, I've taken the opportunity in the packet that Shannon presented to you. Almost every single one of those counties in Florida, I have communicated with my counterpart there to see how the clinic's running, how's it going, and I didn't get any bad reports. Everybody's happy.
They're gonna
Everybody's
love it.
happy with their clinics with Marathon.
Love it.
So.
And the community's gonna like people one, I get it.
And again, I'm so happy that People One is here for the community, because, you know, that's, again, small employers, you know, they can't open a clinic themselves, but
Gotcha.
they can opt into People One. I think it's great to have that here. And if we have an employee that says, you know what, I prefer the MD over there at People One, I mean, they can do that on their own. if they want. I think, that was Tammy's point. She was like, well, I'd rather see an MD, and she's like, she can opt into People One. Any individual can, and so.
Can y'all go and take a look at a couple of places?
We visited, I know some of the committee visited People One facilities, visited Marathon facilities. In St. Johns County, went to see Marathon, the clinics there, and saw the People One facilities in Osceola. Right.
We
Yeah.
actually had 4 models we were considering.
Yeah, that's right. Yeah, there were some other models too. Other models we looked at too that were just didn't even make it past the kind of the beginning phases. They just clearly weren't a good fit for us from the start.
Ms. Gilliard, to answer your question, and my apologies to People One because I cannot remember because we've had so many meetings regarding this, but I know with Marathon, we get a monthly call because you were speaking about employee data. We have a standardized agenda format now since we went to being self-funded, and that was actually going to become one of our monthly points in our agenda to discuss was the data. So we could, with the idea of, and different examples were used, but you might have bus drivers that might at a different time utilization. Maybe some elementary teachers are a little different depending on when and where we start.
Are the operating hours working for our employees?
People One could do the same thing, I just can't remember.
Let's see, I think 1, 2, 3.
Gave us
What else?
1, 2.
Yeah, I gave 1 and 2. Those are the main reasons there.
Customer satisfaction.
The customer, but the access and eligibility to our employees, that's number 1. All of our employees that are on the group health would have access to our Marathon Clinic. That, to me, that is the big thing. The additional cost, we can't afford to pay People One for all 1,000 to go to People One. We can't afford $1.8 million a year for that. That would put too big of a strain on our insurance reserve. But the apples to apples, $540,000 is covering about 300 members that have access to People One.
So, Madam Chairman.
Yes.
So, I understand what you're saying, but then that leaves 700 people that can't join Marathon for $150 a month that they can with People One. I'm just worried about those people that aren't on the insurance plan, that have no insurance.
Well, and
those are the economically, disadvantaged people.
To be completely honest with Mr. Leary, that is not in the scope of what we're even discussing right now. There is not enough money for us to contemplate covering folks who are not insured right now.
Covering them, I understand that, and I get that, and that's something that we as a board ought to try to figure out how, what we can do to do that, or maybe working with the state or DOE to come up with some type of plan, because if it's happening to us, it's happening to other students.
Now,
My concern is, employee that's not on our health insurance plan can go to People One and sign up for $150 a month.
Indeed.
$450 for a family plan,
Yep.
which is still half the cost of what it is just to be on our health insurance plan.
But that's a comprehensive health plan that is more than just office visits.
Oh, I understand that.
There's a huge difference between what our group health family
I
plan
understand
and
that.
that. So
Yeah,
I just
I
want to
understand.
make sure there's, it's not, that's not apples to apples either.
But at least it gives them some opportunity. So
Sure.
my question is, there's no opportunity with Marathon to have for an employee that isn't gonna ever be on our health insurance plan to somehow become part of the Marathon plan, since it's all ours. We own the property, we do run the facility, everything, it's our. There's no opportunity for them, an employee, to do that?
Yes, please, because I think ultimately, I believe that would be up to us to decide. However, they're not paying any premiums in, so those pass-through costs would come to us, and that would cost us, for them to go visit.
I mean,
Why would it call?
one option.
Pass-through costs, yeah.
Sure, if it's
Go
all
ahead.
right
Absolutely.
to
Sure, go ahead.
help you with this question. There's no restriction at Marathon Health of who you would cover in the file of eligible members to use the center.
I'm talking about
Yeah, just
an
access,
individual
sure.
going to you and joining.
I believe what the question I'm hearing is who pays for it? Who pays for it?
If they're not on our
And
plan.
if they're not on the plan,
Yeah,
and out of what fund is it paid for? And if a decision were made by the board to allow individuals who are not on your health plan, but to have access to your health center. Could that be possible under Marathon Health? That answer is yes, that can be possible. The difference is how is it funded? And one option, I mean, I'll just throw this out there. I heard some debate going on about a paycheck deduction amount. And if there were an interest to have a paycheck deduction amount occur for those individuals, and then you collect that paycheck deduction, and then you use that paycheck deduction to help offset expenses related to those individuals that would now use the Marathon Health Center, we don't restrict it. It's just, it would just be the funding methods by which you choose. So if you decided to say it costs, or you wanted to collect $150 or something from a paycheck deduction in order to help offset your expenses, to have the non-health plan eligible members use your dedicated Marathon Health Center, that can be your choice. That can be your choice.
Well,
Go ahead, Phil.
It's funding.
So I think we're still not talking apples to apples. I'm not talking about us, the district, covering that and them being a part of, the people that are on our health care plan that we are supplementing for Marathon. I'm talking about them as an individual employee of the district, being able to go individually on their own to Marathon and, with our saying, hey, yeah, we want this for those employees that don't have any insurance. I mean, we're talking about custodians and food service workers and people that are making $15 an hour. I mean, there's people that are making $60,000 and $70,000 a year that can't afford the health plan. So I'm looking for the same option that they would have with People One, that for $150 a month, they could individually, as the employee, take advantage of their program. Also, if we went with Marathon, that they would have that same opportunity under Marathon, because that's still.
But they'll have that.
Yeah.
How they have
People's,
that.
People One is here.
He said
They can go to
They
People One.
actually, they would probably be
Wouldn't
happy
have
to
to
take
provide
them.
that.
And having,
But
go ahead, Phil, go ahead.
wouldn't it be cheaper? I mean, if we already own the facility, I mean, it's all school district taxpayers.
Well, if you're
funded.
talking about them, if you're talking about people who don't have insurance,
I understand they go to
and
People
they're
One,
going
but
to, and they're going to pay for it. If you're talking about those individuals going as an individual to try to, get services, they can go right there to People One and have it for
For that
$150.
person that's in Crescent City High School that wants to, go to a facility that's associated with the school district. I mean, I
Then
just
they-
think there ought to be an opportunity for
I
a school
think-
district, if this is all school
Jonathan
district
wanted to say
control,
something.
that those employees ought to have the
Mr. Lee,
same
I think one of the options there would be, we have Plan E, which is a low premium. We have a very low-cost health insurance plan on our school district insurance, the Plan E. Now, not talking family stuff, but the individual plan there, what is the,
Correct. So that's what we were talking about, and I was gonna chime in. You have the $150 cost that would get them in here, and an option that would be viable for Marathon is if they opted into our lowest cost health plan, which is $96 a month, then they would have that eligibility to be part of Marathon that the district pays for.
What I was,
Which is even less.
and Jonathan, what I was trying to chime in on a while ago was, having chaired Florida School Labor Relations Board, like you've heard ad nauseum from me for 3 consecutive years in the past, part of this goes to the actions of a prior board can't bind the actions of a future board. It may be that we find a way to, at some point in bargaining, to make situations that might be helpful to employees. But that would come only in bargaining that, what I'm saying, it doesn't really matter what policies you have. A majority of vote of the board can override one of their policies at any time. My concern is that it may turn out to be, at some point, if you've got employees that can't afford it, it might turn into a bargaining tool at some point in the future. But I'm just kind of throwing that out there.
Are we still in
we have
open enrollment?
conversations about insurance
Mr.
contributions. and
Moda,
stuff.
are we still in open enrollment? It's done.
It'll be in,
Started
that'll be in
yet?
October.
Okay,
right.
because the 96 I mean, that, yeah, I'm thinking about a family member now personally that, and then be open to
And they would be on,
Marathon.
they'd be on our list of employees who are covered by the insurance plan and be eligible to visit the Marathon Clinic. That's correct.
Madam Chair, if I may.
Yes, ma'am.
And Phil, I just wanted to bring this up because I'd made a note. When you were saying there's like 700 people that are not on our insurance plan, and you seem to indicate that they were uninsured, and I would really argue with that because I think a lot of people who work for our district,
Their spouse's
I'm not
insurance.
saying all 700, but I would think there would be a reasonable amount of that 700 that is insured on their spouses. You know, we've got spouses that work elsewhere in the county, or even out of the county that may have, you know, until.
I think it would be a significant number based on our socioeconomics, you know, for the county and our poverty rate. It'd be, you know, it may not be 700, but I bet it's way over 500.
But again, I mean, we're offering something then with our least expensive policy, which is something I didn't know about until just now, which
Yeah,
I'm
the
happy to know.
96,
That would be actually more affordable even than People One, although it's probably not going to have as much of the, potentially not have as much of the services, I don't know, but
On the comprehensive side, it's a high deductible plan, you know, high
Yeah.
max out of pocket, but it's,
Yes, sir. I saw you trying to.
I know very
Yeah.
well right now.
Just something I'll put a couple two quick, sorry. It's quick, Steve. Just two quick clarifications, and thank you for everything. I don't know if I could pull this up, but in the presentations you have, there is an option on there, because we heard the insurance committee very intimately that the importance of having an on-site facility. So we presented 4 options that are available. One of those options is an additional dedicated facility for the school district that we would build. And then your folks would have that facility and the community one to access. So if the having a dedicated facility for the school district was important, that's why we built out, you'll see 4 options in there. One of them is us actually building out exactly as you put there. The difference here would be that folks would have the community one and the one for your school district as an additional entry point. So that is an option you have available.
Would that be at our cost or your?
That's at our cost. You'll see on
That's it.
option 4 that we would actually fund the building for that.
But you would own it.
that option does require 1,000 subscribers, right?
No, 300 for the on-site. It was the
Right,
community.
1,000 for 300 for the onsite, and that would be 540,000. 1,000 for the option 2, right? Which was the
Option 2 is like another one, a full one in the community. So let's say you wanted by Crescent, you wanted a whole nother facility. So my point is we're flexible of using our community facilities and building out one that's dedicated to your employees as well. The second, so options, you take a look at those. We're happy to follow those. The other point, and to your point, sir, about if all 1,000 folks opted into using People One Health, it would be $1.8 million. That math is 100% correct. But because all of those folks would then not be using MRIs in your plan and physical therapy and behavioral health and all the other services, your total plan cost would actually go down by about 30%. So although dollars and cents we are more expensive, when you look at it, that's not the story. The story is when your folks get all the health care that they need, everything, how much is that total cost? So that total cost on our side ends up being 30% less expensive, and we'll put a performance guarantee behind to make sure of that. So I don't want it to just look at total, the 1.8 million versus 668. That's not the whole story, because your folks still have to get MRIs and physical therapy and all those other services. When you add all of those up, how much is each one? People One Health net is actually less expensive. I just want to look at that from apples to apples standpoint.
That's why I mentioned that it's a difference about 1.2 that we'd have to make up for in savings on all the included services. You know.
Yeah.
Yeah, they're not making it easy.
Just a couple quick comments on options 2 and 3, which are the kind of a dedicated full clinic and then the little satellite on site. For those do require minimums of kind of a guaranteed 1,000 for the full clinic that's ours, or 300 for the kind of on site kind of satellite clinic. The satellite one does not include an MD. That was a PA, I think, in the details on that one.
Apples to apples.
Yep.
So whatever, yes,
Yep.
we can step it in with.
So those options did not include an MD, just kind of broach that. But again, we come back to the issue of if we can't guarantee 1,000. Again, we can't afford 1,000. If we do it with 300, then which 300 do we pick? Because only 300 then still have access to the clinics.
Well, and that was my.
The eligibility is that's still my number one issue. Is
And my
who can't
disappointment
go to the clinic.
with us not having our county employees involved at some point in this, we could have worked together and found facilities in South and West that the school district could have worked towards but I mean, that's not the job. The insurance committee didn't see that as their focus, but I just see opportunities here that could have been made if we'd have worked together and early on, but.
I don't want to speak out of turn here, but I'm pretty sure as a committee, we discussed, we have availability of buildings at this time, but
And they
in my opinion, that ship had sailed with the county before we were
I got
able
you.
to even
Well,
participate
that's
in
what
that
I'm saying.
conversation.
That's my disappointment that that ship had
Because
sailed.
we thought, we got buildings,
That's completely the opposite of what I heard, Mr. Buckles, because the county was assuming all along, and in fact, the chairman of the county commission, I met with him a month ago, he asked me to meet with him. They assumed that we were working together and didn't realize that we weren't until, just recently, so.
I don't think with the
There's never been a
building choice,
there's
that
never been a
was-
conversation
we
at
were
insurance
not.
committees. There's never been that conversation at all.
I don't think so.
They've never,
Yep, never reached out to us.
I'm unaware of anybody
Yep.
from the county commission ever being in any of our meetings.
Well, that was just a thought that I've had because I've carried it in my mind for a lot of years. But anyway, be that as it may, we've still got to come down to what we feel like is best for our employees at this point. Or do we continue where we are and continue to digest this? I don't know, Madam Chairman. That's, y'all, somebody gonna have to say
I will
something.
give you some direction on that, Mr. Buckles. There's 8 members of the committee, 4 from the union side, 4 from the admin side. Our job is to look at everything and bring the recommendation to the board,
Right.
which is what we've done. We made the recommendation for Marathon that has been brought to you. It's your job to say yay or nay. If you say yay, obviously we'll go with Marathon. If you say no, that's fine too. That's your decision. But I would ask, at that time, if you would give us some type of, for the committee, some type of direction to go to if you were to say no, and we'll do our best to bring back recommendations that'll help our employees.
I know you represent the administration and they represent the bargaining unit, which goes back to my point of bargaining. And it looks to me like you've got your recommendation. I do see promises down the road or promising scenarios, but I just wish that we could have looked into them, and it's kind of a stretch now
To
to.
say that, Mr. Buckles, I'll say that we have looked into this.
You have
We've spent
looked
months and
into it.
months and months looking into this. And that's where we've come to the recommendation of Marathon. We have done due diligence. We've looked at People One.
I believe-
How long has it
We
been?
talked to Jordan several times. We've talked to, we've had a lot
couple
of
of
meetings.
years,
And again, it's a great community model. It's just, I don't think it's right for us. I think it's great for the community. I think it's great for small business owners or for the small employers in the county. But we are large enough to have our own. And make sure that all of our covered members are eligible.
Madam Chairman,
Okay.
I guess.
Can we
Well,
get
we're
a board
still-
discussion now?
Yes, that's right. What we'll do is call for a discussion, because then we're gonna put it to a vote.
We're
Well,
voting.
no,
Voting
no, we're
tomorrow.
not voting today. Okay, so then, all right, then let's go ahead and,
Madam Chair, can I just interject? It is, just as an order of business, it is an unfinished business that, I guess we're planning on putting on the next regular board meeting.
Okay.
Now, there is a board meeting tomorrow, but that is a special board meeting, and it would have to be, an emergency item if you chose to do that. I'm just letting you know what your options are.
Okay.
Whatever the board, determines.
I would say advertise it.
Strictly the
All
marathon
right.
contract is what I was talking about.
all right, Mr. Paul Smith?
Yeah, I just wanted to say a couple of things. And when we start talking about taking money from the insurance fund, I'm keenly aware of that. I've asked Rhonda ad nauseum how much was in the insurance fund over the 30 years that I've been affiliated with the insurance committee, Tony Thompson before her. We need to tread lightly when you start talking about taking money from one and putting another. The cold hard fact, and the thing that Benji was dancing around, school district doesn't contribute enough money for insurance. People want to know why our family plans are so much higher. It's not because of the rating so much, it's because the contribution is a lot more from the other entities. So, you know, Phil, your sister was in the newspaper about that back before I started work here 32 years ago. And Benji mentioned it a few years ago, well, about 10 years ago, about the contribution not being adequate. You know, and the only thing's changed is we've gotten older. And so, you know, I'm just telling you, tread lightly, because I've seen that insurance fund ebb, I've seen it flow, I've seen it go away. And it's not a pretty picture when the insurance fund goes away. So, and you start talking about employees not having insurance, that's when it really hits the fan.
I remember his sister standing in a
So
chair
before we
being on the
leave,
front page of the paper.
Mr. Lear.
So did the insurance committee envision that the 1.3 million startup cost that would be out of pocket would come from the insurance fund?
That was my thought process. Yeah, we don't have any money anywhere else. The one thing about the county is what they probably pay 2 to 3 times what the district does toward the employees' insurance. You know, and so there's a vast difference. The money coming out, yes, it would, and I agree that the initial cost for Marathon is going to be more, but you know, and I'll be honest with you, it doesn't matter to me who you get. In fact, I won't even be able to utilize it. So I mean, but I'm not going to go there. The insurance fund is something that needs to be looked after and really, really concentrated on, because you got different nuances. When this happens, this happens. I mean, it's action and reaction. So maybe Rhonda has been great in taking care of us, and really, I hate to see her go. I hope Jonathan got those genes, but I really, it's something that we've really got to pay mind to, because that's, you know, we talk about what the fund pays, but what it says in contract language, but that fund takes care of a lot more than just what's in contract language. So I just tread lightly.
Well, that's why I mentioned collective bargaining, and I know that's not something we're meeting about today, but this is, and it could impact bargaining at some point if some of these employees who don't draw enough money want to be a part of insurance. It could be a tool that's used at some point in the future. And I hesitate to go into it much deeper than that. I think I've said enough, you know, to say there is opportunities and options here. So,
All right, Mr. Lear.
go ahead, Phil.
Thank you, Madam Chairman. So let me just be clear. The startup cost coming out of the insurance fund is a deal breaker for me. I think the insurance fund is sacred, as Mr. Smith has indicated. When it was raided under the Townsend administration several years ago, was a huge mistake. When I look at the comparison in savings and cost that's been presented by both entities, it's clear also to me that the benefit cost ratio and analysis favors People's One. And we don't spend that $1 million up front to set up facilities and do all these other things. Y'all may disagree, but you know, to me, and you know, I'm just looking at the information that I've been given. I would have liked to had this conversation, you know, 1.5 years ago when Marathon, or when People One first made their presentation, and then I think Marathon did not long after that, because you know, I'm not, as a board member, going to sit up here and just, you know, and all due deference to the insurance committee, but I want, in my heart and my mind, to know that we're doing the best thing for our employees, and also helping those people that need the most help of our employees, and also financially protecting, you know, our decision to go to a self-insurance fund and protecting that fund, you know, at all costs. Thank you.
Yes.
Madam Chair.
All right. Mrs. Wagner?
And Phil, I just want to say, because I have waffled through, you know, I haven't been on the insurance committee forever. I don't even pretend to know everything about insurance. I do a lot of listening and note-taking. But again, when People One first came, I was just like, oh, this is amazing. I mean, I just really, really, really dove right in thinking this was fantastic. And insurance, not just accessibility, but affordability has been a big issue for me since before getting on the board. So I'm big on the insurance issue. One reason I wanted to be on the committee. So, but I would say that everything you just said that was important to you, protecting the funds, every single item and more, I have heard, it hasn't come from my mouth, but I've heard this committee go into in depth. Just almost every single meeting, their entire goal, and I'm not just trying, I don't know everybody's names yet, you know, so this is not a personal thing, but it is when I opened my mind to looking at the other options that were made available. And it's, again, these are two great options, as David said, but they went into so many details about what is best for our employees. And I just want to state that in front of everyone that those, I don't want anybody thinking the insurance committee was just going, you know, this or that. They are very different groups, and I think both bring some things to the table. But the committee, I don't know what, if we were unanimous or how that was, but the committee's recommendation was for Marathon, and it wasn't a light decision is my primary point here, and they really went into depth on it. So I support the Marathon choice at this point.
Mrs. Pickens, Mr. Buckles?
I've been through this type of thing so many times over the years. It always boils down to what the employees want and what's best for them. And I'm torn because of the opportunities for the entire county, but nobody that I know of has really partnered with us to do that at this point. So I'm going to support the recommendation that the insurance committee got. Just time, you know, like I said at the start of the meeting, a bad start's better than no start. We've got to start somewhere. I've had people in here pointing their fingers and yelling at us about building schools. And you know, at some point you got to start building schools, and you know, you go from one situation to the next. But I think it's time to fish or cut bait and move forward. And some people like it. I would like to see us find a way at some point in the future to bring more employees into the pool. And you know, like I said, the action of this board
That's what they stated.
can't solidify the actions of a future board. A board can always change their policies by a majority vote. So, having said that, I'll pass it on to the next person.
Mrs. Pickens?
I agree wholeheartedly about the insurance fund, and it, to me, it is a very scary thing to have to, build out for Marathon. Another concern of mine, though, is exactly what Mr. Model said, is that Marathon allows every one of our employees that's on our insurance plan to go to that facility. And we can't afford for that this is how I heard it, and I'm very thankful that I have a week to mull and talk about this. But I don't know. It's very tough. It's very tough, and I do, like Mr. Buckles, I wish that we had maybe us even be more proactive at the beginning of this whole thing. And but kudos to the whole insurance committee, because they do really delve into it extremely deep, and I trust their opinion.
And Holly, in fairness, at some point in the future, beyond whatever's decided today, we still have opportunities to work with our other governmental agencies in the West and the South if they want to, find ways to do that. So, just, I'm done.
Can I ask a question? And I wouldn't even start to interpose my thoughts in place of the work that committee's done over hours and days and weeks and months. And I agree from listening. I'm sure that they struggled with the decision and made a decision they think was best for the school district. I have no problem with that. Here's my question and it's primarily to the Marathon folks. As an attorney looking at a contract that a client's about to enter into, where the contract has a lot of estimated costs, okay? I see a lot of question marks. For instance, your $449,000 build out is an estimate. The district will pay more if the bids come back higher. Your cost of providing your staffing is an estimate. The contract says the district will pay more if you end up having to pay more to hire people. Your model that ended up with a $55,000 a year first year fee, which goes up by 5% every year or more. Can you tell me how many participants that model was based upon? So I'm hearing that your eligibility for Marathon will be based upon your being a covered employee, you being somebody who's right now getting insurance. And that's only about 300 out of 1,000, I'm told. Is that correct?
No.
What is it? I'm sorry.
7,000.
There's 900 that are covered? Oh, I'm sorry. Okay, I apologize. I misunderstood that number. So your total employee base is? Okay, so you don't have quite 50%. You got a little bit more than 50%. You're 1,600, 900, right? Okay, I apologize. That was wrong. So your model was based upon 900 people having access then?
Yes, and our the staffing matrix that we offered in the model could actually serve up to 1,200,
cool.
So without any additional cost. But yes, but you had a question for me, sir?
Yeah, my question was this. I mean, I'm still boggled at the $7 lab cost, because I know what I paid the last time I got a full panel at the hospital.
It's incredible.
Well, my insurance.
Those are
charged that,
averages,
and then
yeah.
I paid, what,
Sometimes it
$180.
can be a little up or down, but average.
That's $7. I'm still kind of.
It's one of the greatest benefits of being a health center.
I guess so.
Economies
Yeah, I
of
guess
scale.
so. But I was just wondering, your experience is the best teacher. After a year, we're going to know what the thing costs. But we're locked in for 3. And then the other question I've got is ongoing maintenance and replacement. So you build out this facility for $450,000 plus, and it's fine day one. But if the medical business is like most, there's going to be a need for replenishment, replacement, repair, substitution of that stuff that's in that. I say stuff, you know what I mean, in that facility. I guess my question is there any room for that contract? It was originally 5 years. You guys came down to 3. I appreciate that. You agreed not to make California or Indiana, I guess it was that right? The only place where litigation can be filed. I appreciate that. You agreed that the law of Florida would apply instead of law of Indiana. That's really helped me, because I have no clue what the law of Indiana is. There were a number of changes that you agreed to make, and I do appreciate that. Is there any possibility of having any kind of look back after a year? I guess I'm just trying to look for some way that if there's a need to adjust something, it could be done from the school district's perspective after we have 1 year of experience. I don't know. Maybe that's just something that's too far to reach.
Yeah, we're constantly going to be evaluating your program through the population health management reporting and working with your consultants and pulling in your health plan data. There's going to be a constant continuation and circle of information that's being provided. Most of the time, a lot of different elements are derived from that, even to, how your plan designs operate, how your premiums are operated, how is the utilization of your center, what are the type of appointments that are being provided, and your clinical outcomes. How many people are we engaging for all these different aspects? And it's just a continuous process over time.
So is there a possibility to modify, I guess is where I'm getting to after a year. Let's say that your imaging costs are way more than, you've got 900 people who may have families. Right now, your imaging costs are not covered under the contract. They're not there. Having a grandson that recently broke his leg in 2 places at your high school or junior high football, I know a little bit about what imaging costs are. If you go back for a year and you look at your imaging costs, and they're a lot higher than what you thought they were going to be, is there X-rays, MRIs, CAT scans, all that kind of stuff? Is there a
Yes, sir.
possibility for the contract to be modified so that for a bulk rate, for a flat number, the district gets imaging included?
There is constant continuous improvement, and it actually is one of our more sought after requests over time, is to evaluate some high performance item like the imaging or any other specialty rather in the community, and help work with you all and your designated representatives, your consultant, what plans you have in place, and perhaps even lean into what might be considered like a high performance network. I know that this is something that many of our school districts ask us to do, and that data collection that you get after a year makes it ideally suited to make those decisions, and even other decisions about bringing maybe an enhanced, like even more robust mental behavioral health to the services that you're providing at your center. Every one of those things are tailored, customized, and consulted on with your representatives, and with in tandem with how your health plan's operating and your consultants. So I think you even asked questions too about the bid structure that was put into the agreement in regard to your build out. I love to point out that your committee actually took quite a bit of time to look at some potential available space. Our team at Marathon Health did as well. We had an architect on the line. We had project managers on the line. And so the quote that was actually provided back to you was realistic and conservative in approach, because it's never our goal
We
to
modify the contract to say that it won't exceed that amount.
I can't recall what it says right now in there, but
That's kind of a joke. 449,000 is what it says.
Yes. So there are subcontractors underneath our, as you could see, because you'd see the amount listed for architects, and certain things are flat fees listed in there. But I'm not sure if the cost of wood is going to change or something over time. And that's why there was a little bit of flexibility in the estimation that was provided to you all. I think you asked another question that was about the staffing element, and so one thing I wanted to point out too is in the rates that we offered, it did include both medical and office supplies are built into that monthly rate. So as we're replenishing the gauzes or the, tongue depressors, or just the clinical aspects of medical supplies or office supplies, that is built in. Say if we had to hire an individual in a community, and again, because you have so much control over the cultural fit of the staff that we're going to hire, if the most ideally suited candidate came along but was asking for a signing bonus or something that was in excess of up to 10% extra is what we've already built into our contract, we would always come back to the district and ask if you're interested in this particular candidate, knowing that this individual is a little bit more. That's why those provisions were listed inside the contract in that way. Hopefully that answers the question.
Yep, I guess time will tell, but after a year, when there's an experience base to look at, then maybe the board will want to look again at
Well,
whether
that's-
there's something that could be, you know, tweaked that might give you more bang for the buck.
That would be the ideal.
Board.
Thank you.
And the county may feel the same way. If they go with whatever they choose, they may want to come to the board and let's try to resolve and see if there's,
They've already signed a contract.
well, I mean, but I don't know how many years they're locked in for, but they may come back in a year or two and say, hey, we, want to get with you guys and
Discussion with their administration last week.
build something in Interlochen and something in Crescent City, so I don't know. We'll cross that
Okay.
bridge when the time
All
comes.
right, Ms. Stodem?
So I wanted to come up right
You
after.
need to- Oh, okay, before you, all right, Mrs. Pickens, I'm
No,
sorry.
I've got an appointment.
Okay, all right, because we're not voting today, so,
Well, we have to vote on,
oh, okay.
Oh, a motion to put it on for, put it on the agenda?
It's planned for the 17th, but if you wanted to put it on tomorrow, you'd have to.
17th, keep that. So let's, all right, get a motion, and then we'll get a second and we'll
I
vote.
move we take up the contract on our regular board meeting on the 17th. Oh, okay.
okay, good.
Okay, we didn't? We don't. Oh, okay, so then it, make sure it stays, yeah, okay, so it's on. So you may excuse yourself, drive carefully.
Hey, can I say one thing before you go and Jonathan speaks? I just want to thank the insurance committee for all the time they've put in. And I've intentionally sat here quiet because the insurance committee actually represents the administration and the union. And again, I wanted this to be the board having a discussion about both plans. And I'm glad both entities are here. And thank you, Mr. Bates and Mr. Bates for being here, because I think it's been a good discussion, whatever it turns out. I think we want what's best for our employees. So I just appreciate all the facts being laid on the table and all the apples and the oranges that we compared, so.
All right. Traveling mercy.
Careful.
Kind of following up on that real quick, I think whatever decision you guys make is going to be good. Personally, I go get my wellness checkup, and that's all I do regularly. I'm reconsidering that, obviously, because we have two great options that are coming, and it'll be more affordable. It just makes more sense. I wanted to come up when Paul was talking about the insurance fund, and I know in the first public budget hearing, there were questions about it, how much and everything. I know we won't have that again until the 17th. So I wanted to give you a quick update since that was, again, brought up. This past year, fiscal year in close 6/30, it increased 1.4 million. That is half year on our old plan, half year on our new. So I know that's just a number right now, but when you look at prior year, it was under $800,000 increase. Prior to that, under 500,000. Prior to that, back at 800,000. So we're already seeing just that quick increase of a certain amount. Claims even went down that year. You can argue whether that's attributable or not, but claims went down 900,000. So just want to give a quick update on that. And in the discussions while I was waiting, it is $7,001,177.20. So that is what our insurance fund is up to. I don't know what the highest it was when Rhonda informed you all those years, but that's the highest it's been since 2018, and that is the lowest amount of claims it's been since 2018.
Is there a policy that dictates what can be paid out of that fund? A written policy?
I'm not sure.
I don't, even if there was a policy, the board can, by majority vote, override it, and that's why I feel what he did was protecting that fund with a supermajority vote was a very good move, because, you don't know what may happen in the future, but, I know that in 2008, when I no longer was school superintendent, we had millions of dollars in the fund, and it was depleted rapidly on many different things, and I don't have those at my disposal, but Jonathan may have thought of some by now, I don't know. But, really, I think it can be used at the discretion of the superintendent to direct it if the board approves for most anything that they decide, but I don't know that, Jonathan, you probably know.
Well, I don't know, are you finished? Because I have a question.
I was going to bring up another point because it kind of came up in y'all's conversations. And a point, I get it's not really a point I wanted to make, but I just wanted to say that the fixed rate cost, when you take the two costs between the two, and you take the fixed rate cost of Marathon, it comes out to $60 per person, just shy of it. And the other side is $150 per person. So that is a big difference, but also consider if someone comes under $150, then yes, you're losing if you go with People One. If someone comes over the $60, then you're winning. Or if someone, I mean, it goes both ways. Either way, when you look at that dollar amount, it's a gamble with either company. You don't know what you're going to get. So it is what it is. So just keep that in mind. But my main thing was just the insurance fund. Since you wouldn't have another update till next week when you're actually voting on this, I want to go ahead and let you know we have seen a significant increase since self-insurance, and it is sitting at a healthy $7 million right now.
Yes.
I have a question for you. So during our first board budget workshop, your mom, who's still in charge then, said that we were moving the our building staff, the maintenance staff, all under what was originally under our capital improvements were paid out of there. That whole department's paid out of there. Now is being paid out of general fund because we needed every dollar of capital improvements for the cost that there'll be some additional cost for the new schools and other construction as we go with respect to our capital projects. This plan, the Marathon plan, we're gonna be pulling $1,300,000 minimum based on, estimated costs, could be higher, out of our insurance fund, which, number one, I think is in conflict with the policy that the board adopted to not to do that without a supermajority vote. There's not the money in the capital improvements element, as I understand, or the capital improvements budget for that 1 million to come out of that for those upfront costs. Is that correct? I mean,
So the capital money is earmarked for special facility schools, as we all know. And everything discussed in insurance is that insurance fund would pay for this. Technically, you could use capital money if you had the capital money. But that being said, first I want to address the $1.3 million comment because the annual fee is $669 and the build out was $630 something you said earlier.
Whatever the numbers are.
So the 600, if you go with Marathon, the 669 is going to be what it is regardless. So that shouldn't be lumped in with the 1.3. The build out cost would be separate. And I'll throw another little tidbit on that. We went up 1.4 million this year, only half a year under self-insurance. So, if you were to work with projections, I would assume under projections that you would be fine with that. That is a one-time cost. Now, Mr. Holmes brought up a great point earlier that repair and maintenance cost, that will be a thing down the road. How much? I have no clue. I'm not in the medical business, as mentioned earlier for all of us. So
Let me mention a point of information that Susan just reminded me. The supermajority, I think that was brought up as a proposal for a new policy. I don't think we've actually developed and approved that policy yet. I remember it was brought up. I don't think we've actually developed the policy and passed it. I just want to, as a point of information. So I remember it. Right. Yeah, we're going to develop that, but I don't think it's been passed as policy yet. So I just want to make sure we bring that up. So
either way, whether it's a policy or not, to take that money out of the insurance fund, I think is a huge mistake, irregardless of how flush we are in it currently. And then secondly, for us to then now be responsible for one, maybe additional facilities down the road. I mean, again, we're in a business for schools and education, which we have taken a huge step, in that direction. And I just think y'all need to think about that very hard, you know, before you decide.
Okay. All right. Anything else to come before us for the good of the order? Anything else? Mr. Bates, anything else? Insurance Committee?
I think I'd just make one comment, Ms. Gillard, that I am completely in line with Mr. Leary on setting up protections for the insurance reserve fund. And in my mind, the $669,000, that would be paid out of the insurance reserve fund because that's the cost of insurance. The build out of this building, that's an investment in our group health plan. And it absolutely would be appropriate to spend insurance reserve money on building out the clinic, in my mind. I would argue that even if the policy were already in place, that wouldn't apply to spending money to build a clinic. That's part of our insurance program. And $500,000 investment here in a clinic that will, save money in the long run. I think that, to me, that's a no-brainer. We make that investment and go.
And this, I'm sorry, and this is not a new facility that we're talking about. We're talking about the training center, unless something has changed since a few months ago. And we're already maintaining that facility. So, I mean, those costs are already in the cake.
It's already our building.
Yeah.
That's an empty building?
No, it's occupied by mental health staff.
And they said,
That's so that it wouldn't be empty.
they said we're already maintaining it.
The plan is just to make part of that particular facility the clinic. The other part will still operate as PCSD training and office space.
Okay. All right. People, one? Anything further? Yes, you're good. Marathon.
Thank you. No.
All right. Mr. Superintendent?
Good, thank you.
Attorney Holmes?
No, ma'am.
Anyone else from the board? Okay. We're done. Thank you all.